Welcome to your Week 2 lecture. This week we will look at chapters 9 and to 11. It is best if you read the chapters prior to watching the lectures. Let's get started. This lecture will continue where we left off last week. As you recall, we looked at the pathophysiology of our cells and tissues. We looked at how the parts of cells called organelles, along with our genetics, affect our overall health. This week we will look at how and why our cells use inflammation, how they fight infections, and the various infectious agents that can disrupt our homeostasis. And lastly, how our immune system works and what can go wrong with it. What is inflammation? Is it good or bad? The answer is neither. It is a normal body response to a set or injury. It can prevent the spread of injury or infection, and it awakens the body's defenses to the area in question for a quicker response. It can be localized or widespread. It can also be acute, meaning right now, or chronic, meaning over a long period of time. In the past, the Romans identified the 5 signs of inflammation: rubor or redness, tumor or swelling, calor or heat, dolor or pain, and then loss of function. Any part of the body with these symptoms is likely undergoing inflammation. Acute inflammation is the most common. It happens to all of us. Just hit your knee against a table by accident or get an infected hair cell, and there it is. The 3 phases of acute inflammation are increased vascular permeability, cellular chemotaxis, and systemic response. Again, when injury or infection happens, then you will have acute inflammation. The steps are increased vascular permeability, which lets in fluid and allows white blood cells to enter tissues from blood cells. Then cellular chemotaxis, which makes white blood cells and platelets travel from blood vessels into the injured tissues. And then finally, the systemic response to the inflammation, which can come in the form of pain, fever, hypotension, etc. Increased vascular permeability comes from dilated blood vessels and allows fluids to rush into areas of inflammation. This helps to dilute toxins released from bacteria that may be present and bring in white blood cells and platelets to deal with the infections and bleeding. The fluid can be transudative or low protein in content, or it can be exudative with a high protein content if bacteria are present. Cellular chemotaxis is the movement of cells in the body, particularly the white blood cells and platelets. The chemicals released during inflammation bring white blood cells to the area in question, like they are in a taxi. This picture here was made to help you remember this term. The systemic response may be as simple as pain or fever, but it can be as serious as SIRS or SIRS, which is Systemic Inflammatory Response Syndrome, or even sepsis, depending on what the inciting factor was that initiated the inflammation. This figure illustrates all the causes of inflammation and what systemic responses they can elicit. For example, a bacteremia will lead to sepsis potentially, while a trauma could lead to SIRS or SIRS. Which pro-inflammatory mediators are involved will determine what the response will be. And the more serious and widespread the cause of the inflammation, the more mediators will be involved. Tables in the textbook help to illustrate important concepts. This table is based on Table 9-1 from your textbook. These are the major pro-inflammatory mediators. Pay attention to which ones cause fever, vasodilation, increased vascular permeability, and pain. For example, histamine, kinins, platelet activating factor, leukotrienes, and substance P all increase vascular permeability. You're welcome to come back to the lecture and pause here to study this table. You recall the types of white blood cells from AP2. Neutrophils are the most prolific and arrive first and fight bacteria. Basophils release histamine and have some involvement in allergies. Lymphocytes fight viruses. Eosinophils are involved in allergic reactions and fight parasites. Lastly, macrophages perform phagocytosis on invaders and garbage cells. Here are some important terms to know about white blood cells. Leukocytosis is an increase in white blood cell number. Leukomoid reaction are extreme elevations in white blood cell. White blood cell differential helps determine what types of white blood cells are present in the blood. Margination is where white blood cells line up along the endothelium of blood vessels due to chemotaxis. Neutrophils are also called PMNs or polymorphonuclear cells. Mature neutrophils are called segs, and immature ones are called bands. A left shift means many more neutrophils are being made, and many are immature as new ones are being formed. This usually is a bacterial infection. Lymphadenopathy can happen in the presence of infections or an inflammatory response or process. Usually at the site of the inflammation is where you will find enlarged lymph nodes. The lymphatic system is essential for the movement of the lymphocytes as well as movement of lymph. Fever can be good or bad, depending on the cause. The usual cause is due to infection from microorganisms like viruses or bacteria that stimulate white blood cells, which release interleukins and prostaglandins, which stimulate the hypothalamic body temperature center. The fastest way to break a fever is to reduce prostaglandins, and this is done with NSAIDs, or nonsteroidal anti-inflammatory drugs, like aspirin or ibuprofen. Tylenol or acetaminophen will also reduce fever, and can also can steroids like corticosteroids. Using ice or ice baths or a cold towel is very ineffective here, as you must break the chemical process to stop the fever. Never give children with the fever aspirin, as it can cause Reye syndrome, which can be deadly. At the end of acute inflammation, usually everything resolves and goes back to normal homeostasis. Sometimes healing is not complete or overdone in the case of scar formation. Chronic inflammation can happen occasionally if the insulting event persists or the disease process continues. Chronic inflammation can come about from many causes or from acute inflammation that persists for some reason. One example is TB granuloma. See the picture we have here. Acute inflammation and chronic inflammation, acute inflammation becomes chronic inflammation, and there are several types of chronic inflammation. Cardiovascular disease can cause small amounts of inflammation. Neurological disease can also result in inflammation over time. All kinds of autoimmune diseases like rheumatoid arthritis, lupus, for example, can cause inflammation chronically. Chronic infections can also cause chronic inflammation like tuberculosis, for example. We can measure inflammation in the body using CRP, or C-reactive protein, or ESR, or erythrocyte sedimentation rate. If these lab values are elevated, then it means inflammation is currently happening in that individual's body. We cannot discern acute or chronic from these labs. However, HSCRP, which is high sensitivity C-reactive protein, is used to detect small amounts of inflammation in the body and can even detect atherosclerosis in arteries. This can predict a patient's cardiovascular risk for an MI, or myocardial infarction. Here are 4 stages of wound healing: hemostasis, inflammation, proliferation, and granulation, and lastly, wound contraction and remodeling. When a wound happens, it usually bleeds, and the bleeding will persist until a clot is formed. This is the homeostasis phase and the first phase of wound healing. Then after clot formation, inflammation begins. We already covered this in great detail. Proliferation occurs in an effort to heal the wound. This phase is distinguished by a scab forming instead of the clot, and granulation tissue beginning to form along the perimeter of the wound. Remodeling is very last, and this is where a scar or keloid may form, and the wound is no more and now healed. Healing by primary intention means a surgical cut with a scalpel with a nice clean edge, done in a sterile fashion so you can easily suture the edges together to close the wound. These wounds heal quickly and easily, and less likely to scar. Secondary intention wounds will heal much slower, as they are non-surgical with rough edges and loss of tissue and skin. They are usually non-sterile and cannot be closed by sutures. Instead, one would use antibiotic-coated packing inside these wounds and keep them clean and moist. These wounds are more prone to scarring. Tertiary intention healings wounds they're very deep, like puncture wounds, severe burns, pressure ulcers. They cannot close, need drains and packing with antibiotic-coated material and sterile gauze. They're very long in healing and would benefit from skin grafting or even hyperbaric chamber therapy. An eschar is dead tissue that falls off a wound, like a really thick scab. Debridement is removal of dead tissue that promotes new skin formation. Wounds can rupture even if sutured well. Coughing, obesity, falls, and other factors can cause a surgical wound to reopen. If the sutures reopen, then it's called dehiscence. But if there is bowel exposed, then it's called evisceration. Keloids are hyperplastic scar formation. Contractures are inflexible shrinkage of wound that can limit mobility. Stricture is a narrowing of a usually open area, like an esophageal stricture, for example. A fistula is an abnormal communication between tube-like structures, like a tracheoesophageal fistula, or a fistula between bowel and bladder. An adhesion is an abnormal band of internal scar tissue, usually from repeated surgeries. Pressure ulcers are staged based upon their depth and caused from compression of the skin over a long time, usually from an immobile patient laying on the same position for a long time. Risk factors include low body weight, immobility, protrusion of bony prominences. Prevention is key by turning risky patients often. Nutrition for wound healing is essential, and providing protein is very important along with the right combination of vitamins. Providing a patient with a good access to all these, like an Ensure shakes or any of the nutritional supplements, is most ideal for wound healing. Now let's look at some major causes of inflammation, the infections. Here are some important terms for infections. A host is one colonized by the pathogen. Pathogen is the microorganism that is invading the body. Colonization is when the pathogen lives in the host, and there may not be symptoms of infection. Infection is the microorganism enters the host or the infected. Virulence is how much disease the pathogen produces. Reservoir is a pathogen source. Foci is an inanimate object carrying the pathogen. And lastly, vector is a living being carrying the pathogen. Usually has no symptoms. Let's start with viruses, as these are the most common types of infections. We have viral infections constantly, with most being asymptomatic. What is a virus, you ask? A virus is not a cell. It is a genetic material covered in a protein coat with receptors on its surface that mimic cellular receptors to trick cells into letting them in or allowing it to insert its genetic material into the cell's plasma membrane. Viruses only care about replicating themselves and need a host cell to do so. Some can stay in a host forever, essentially, while others are self-limited and can be eliminated easily by our immune system. We've all had a cold. There are 3 viruses that cause the common cold: rhinovirus, adenovirus, and coronavirus. Yes, I said coronavirus, but not COVID-19. That is a novel coronavirus for the human species, so it is new. Influenza is a virus as well, and there are 3 major types. This virus can be deadly as it leads to pneumonia. Epstein-Barr virus and cytomegalovirus make up the 2 viruses that cause mononucleosis, or the kissing disease. Rubiola is the measles, and rubella is the German measles. Varicella zoster is a virus of the herpes family that can cause chickenpox the first time you get them as a child or adult, but they will always be with you like a good friend unless you have a vaccine. Later in life, the same virus returns and can cause the shingles, which will break out in one dermatome of the body at a time. The mumps is swelling of the parotid glands, but can cause sterilization in males. Fifth disease is from a herpes family virus that is a normal virus in children and gives them a slap cheek appearance. Herpes simplex virus causes cold sores, and this type depends on where they're at. So HSV1 is around the mouth, and HSV2 causes genital infections. Poliomyelitis is a terrible virus causing paralysis. Franklin Roosevelt contracted this virus in young adulthood and ended up with the inability to walk. The vaccine has helped make this virus much less prevalent, but it is still a problem in the world, especially in the third world countries. The term aseptic meningitis means a viral meningitis. Hantaviruses from rodents and can cause a hemorrhagic fever with renal failure or heart failure. West Nile virus is from mosquitoes and is prevalent in late summer. It causes encephalitis, which is a viral syndrome that results in confusion and headache. Most are asymptomatic or just have fevers. I had one patient in the past who had to stay in the hospital for a month due to encephalitis from this virus. There are 3 hemorrhagic viruses of the filovirus family. Ebola is the worst one. It comes from bats and monkeys, but once it goes to humans, it can be spread from person to person. It must be in close contact, so the human-to-human transmission is usually from caregivers or healthcare workers or those involved in funeral preparations. It has a 90% mortality rate and is very deadly. Marburg virus is very similar and also has a 90% mortality rate. Zika virus is also transmitted by mosquitoes and causes severe birth defects in babies. It will cause microcephaly or a smaller than normal cranium. Viruses are the most common infections. The next most common is bacterial. Now you ask, what is a bacteria? It is a unicellular prokaryotic organism. They can live outside the body and replicate on their own, but if they get inside a human host, they can find all the things they need to help them live in abundance. We do have some normal bacteria we live with every day that are part of our normal flora. But if we get infected with bacteria that does not belong, then it can be a serious issue. Bacteria are identified by their shape, like cocci or bacilli, and whether they stain gram-positive or gram-negative on gram stain. They are given names by genus and species. Gram staining helps us identify bacteria we culture from infections. By how the bacterial wall stains and the shape of the cells, we can figure out which bacteria we are dealing with. Other ways to identify bacteria are by agglutination testing, which we test against antibodies, or we can do serological testing for antibodies in the serum. Again, we have normal flora of both bacteria and fungus. Between the two, they stay at war to keep homeostasis. But if one begins to win, say with an antibiotic treatment, then the other will be quick to take up their space and throw off this careful balance. We need normal flora to help us in digestion, as they will secrete nutrients. In surgery, our normal flora can become a problem with maintaining a sterile environment. Also, if we become immunocompromised, they can cause us harm. Staphylococcus aureus is a skin bacterial pathogen that stains gram-positive and is shaped as a diplococci, which is a 2 cocci joined together. It causes all kinds of skin infections and is an aerobic bacteria needing oxygen. It can become resistant to antibiotics as this bacteria has been treated for years and the most resistant strains are hard to fight. There are also other species of Staphylococcus like Staph epidermis and Staph saprophyticus. Streptococcus is another skin flora that is also a respiratory pathogen. It is a gram-positive and in cocci, but in chains, as seen here. There are 3 major groups of strep based on if they cause hemolysis or the breaking up of red blood cells. Group A beta hemolytic strep can lead to other diseases like toxic shock syndrome, rheumatic fever, or glomerulonephritis. This is due to the toxins produced by these organisms. Streptococcus pneumoniae is the most common bacterial pneumonia and is a typical pneumonia, meaning it presents like we would expect with fever, productive cough, and x-ray showing an opacification like the one here, colored for your convenience. Remember, though, that most typical pneumonias are viruses, not bacteria. The atypical bacteria pneumonias are Mycoplasma pneumoniae, Legionella pneumophila, and Chlamydia pneumoniae. Mycoplasma pneumoniae is called walking pneumonia, as the symptoms are usually mild enough that the patient can walk about without issues. Legionnaire's disease can be fatal and comes from water droplets like from air conditioning systems or produce misters. If infected without pneumonia, then it's called Pontiac fever. Pseudomonas aeruginosa is a terrible bacteria that causes resistant hospital-acquired infections. It is gram-negative and in a rod shape. Meningitis is the inflammation of the meninges or the covering of the brain and spinal cord. This is usually from viruses, but young people can get bacterial infections that can be deadly. Neutral rigidity is neck stiffness, photophobia is sensitivity to light, and phonophobia is sensitivity to noise. Encephalopathy or mental confusion can happen in severe disease. This disease can be fatal. Kernan's and Brudinsky's signs are positive as they are maneuvers that stretch out the meninges. Meningitis, along with some other diseases like normal pressure hydrocephalus, are diagnosed using lumbar puncture, which is using a large needle around between the fourth and fifth vertebra or lumbar vertebra to obtain a sample of the cerebral spinal fluid. If there is bacteria present, then you can find them on gram stain, culture, elevated protein, low glucose, and with neutrophils present. Agglutination testing can be done as well to identify bacteria. The most common types are Haemophilus influenza, Streptococcus pneumoniae, and rarely we can see Neisseria meningitis. This is seen in young college-aged adults living in close quarters like dorms. GI bacterial infections can have many complications. We hear about outbreaks of these bugs every day in the news with contaminated food. Hemolytic uremic syndrome can come about from Shigella or E. coli infections, particularly the E. coli 0157H7. To remember this one, think of the H meaning hamburger, as most of the time this comes from undercooked ground beef at cookouts and young kids. Campylobacter jejuni can cause Guillain-Barré syndrome, which is the loss of neural function in the distal appendages. This can lead to complete paralysis in some cases. We'll visit this bacteria again in the GI chapters. Remember again, though, most infections are viruses, and the viral GI infections are far more common. Cholera has been around since ancient times and killed many people. It is found today in less developed countries due to contaminated water supplies. Diphtheria is a disease that causes pseudomembrane to form in the throat. Pertussis is known as whooping cough, and tetanus causes lockjaw. All three produce toxins, and a vaccine given can prevent these diseases called DTaP, and there's a booster called Tdap, shown here. Botulism is a muscle flaccidity caused from another toxin. We use this one medically to help with migraine headaches and smooth out facial wrinkles. You can ingest this toxin from poorly canned foods. Clostridium difficile, or C. diff for short, is a terrible watery diarrhea that forms from recent antibiotic use. Using an antibiotic for another infection will kill normal bacterial gut flora and allow the spore to take hold, resulting in profuse and terrible diarrhea. Gas gangrene we discussed last week when we talked about infected gangrene. It can be very fatal if untreated. Lyme disease is from the deer tick, which harbors the bacteria Borrelia burgdorferi. It has a distinctive target rash. It is treated with a course of doxycycline. Chronic Lyme disease is controversial. Rocky Mountain spotted fever is another tick-borne bacterial illness. Here, the tick is a vector and bites the human. It has a distinctive red spotted petechial rash. Now let's look at fungal infections. Fungus are mold-like organisms, with the most common being Candida albicans. Candida is part of the normal flora and all over our bodies. It causes infections when the normal flora balance is offset by antibiotics, when lactobacillus is killed off, or if it invades an area it is not supposed to be in. It can also cause problems in immunocompromised patients. Aspergillus causes lung disease in immunocompromised patients. Cryptococcus enters the body through the respiratory system and also infects immunocompromised patients. Histoplasma is self-limiting, except again in immunocompromised patients. PCP pneumonia is an AIDS-defining illness and comes from Pneumocystis jirovecii. Used to be called Pneumocystis carinii, but it was decided this organism is more fungal, and they changed the name. Cocciomycosis is valley fever, and immunocompromised patients are most at risk. This is an airborne fungus, as seen here in the CDC information. Now let's look at parasitic infections. Parasites live off other organisms and not beneficial to their host. In fact, they are usually harmful. Some parasites will transmit another disease as a vector. Amoebiasis and giardiasis are waterborne protozoan infections. Giardia lambda causes giardiasis and is a severe form of dysentery. Leishmaniasis is caused by sandflies being a vector transporting Leishmania protozoan species. Malaria is a parasitic disease causing hemolysis of the red blood cells, and it can be identified on peripheral blood smear with direct visualization of the parasites. Toxoplasmosis is a parasitic infection. The dangers are with pregnant women who scoop or empty dirty cat litter pans. Also, immunocompromised patients should avoid this task as well. Prions are abnormal proteins that enter the body through cow meat, shellfish, and other foods. They cause a progressive degenerative neurological disease as the neurons reproduce those same abnormal proteins. Definitive diagnosis of this disease is a post-mortem brain biopsy. Lastly, we'll look at how we can fight off these infections with our immunity. How do the infections we talked about get into our bodies? The skin provides a natural barrier to infections, but also harbors pathogens like staph and strep just waiting to get in. We can inhale various viruses and bacteria or even fungus, but the ciliary apparatus, along with mucus and macrophages, aid us in preventing infections. The GI tract can also be a door inside our bodies for these pathogens with the fecal-oral route transmission. The normal flora of our gut does protect us from some invaders as it prevents new pathogens from finding an available spot. The genitourinary tract also provides a path for our bodies into our bodies via urethra. In females, the urethra is much shorter and gives them a higher risk of urinary tract infections. Bloodborne pathogens can enter us through open wounds or use of needles. Universal precautions must always be taken when dealing with blood. Mothers can also transmit pathogens to their unborn children. Our immune systems protect us from invaders like we have studied today. There are two primary levels: innate, like all the natural barriers we just discussed, along with some other elements that are nonspecific in their defense, and adaptive immunity, which is specific in its attacks of invading organisms. If your immune system is weakened, then our own flora can attack us, and you will be susceptible to more pathogens than a normal human would be. Immunity, again, can be divided into innate and adaptive immunities, but adaptive can further be divided into natural and artificial, and then passive and active for each of these. Innate immunity is our first level of defense. It is nonspecific. It starts with anatomical barriers and continues with macrophages that phagocytize invaders indiscriminately, as well as nonspecific anti-pathogenic chemicals, and the inflammatory pathway we studied at the beginning of this lecture, as it too is nonspecific in its defensive mechanisms. Adaptive immunity is slower than innate, but very specific in its attacks and can remember pathogens once it has fought them before. T and B lymphocytes both contribute to this type of immunity. It can be passive or from another source of immunity, or active from our own immune system. Again, innate immunity is nonspecific. It starts with our natural barriers like the skin, pH of our stomach acid, enzymes in our tears. Macrophages will phagocytize indiscriminately, invade creatures. They come from the monocytes, which do the same thing in the blood. But these monocytes migrate to the tissues and then become macrophages. Cytokines start up the inflammatory process we discussed earlier, and this too works against the invaders right away. Natural killer cells do just as their name entails, as they destroy viral infected cells and even go after cancerous cells. They are granular lymphocytes. Adaptive immunity is much slower and is acquired. It is specific and contains memory to remember what we have fought before, so the next time it'll be easier. It is made up of T and B lymphocytes. T cells use cell-mediated immunity, while B cells use antibodies or humoral immunity. This type of immunity can recognize which cells belong to us and which ones are invaders. using the MHC or major histocompatibility complex, known as also as the HLA or human leukocyte antigen. T cells are made in the thymus, hence the T is in their name. They are activated by macrophages and dendritic cells which present an antigen. CD4 cells are helper T cells and CD8 cells are cytotoxic T cells. HIV attacks CD4 T cells. B cells come from the bone marrow, hence the B in their name. They are activated by antigens. If activated, then they become plasma cells and produce immunoglobulins or Igs. This process takes time, but they have memory, which will make their attack stronger and quicker the next time they encounter this pathogen. Immunoglobulin are made by B cells, and there are 5 subtypes: IgM, IgG, IgA, IgD, and IgE. The first exposure to the antigen is very slow, but is much faster thereafter due to the memory cell response. If the memory response goes well, then there will be no signs or symptoms during the next attack. Remember, IgM is the first antibody. This table is adapted from Table 11-1 in your textbook. Highlighted are the most important aspects of each type of immunoglobulin. IgM is the earliest or the first one to respond. IgG is the most abundant in the blood and involved in autoimmune diseases, as we'll see in a few minutes. IgA is found in exocrine glands, secretions like sweat, saliva, tears, and breast milk. Ig is involved in allergic reactions, while IgD is involved in hypersensitive reactions. Study this table well. You can always pause the video and to look at it. Acquired immunity comes in 2 forms, active or passive, and these have 2 forms of natural and artificial. Active requires exposure to an illness or vaccination, while passive is given to you either by natural means, like from your mom, or artificial means, like monoclonal antibody infusions. Vaccines are active acquired immunity and expose a patient to a dead or weakened non-disease producing pathogen. This will stimulate an immune response without a disease contraction. Boosters may be needed to stimulate memory, and women who may become pregnant or are pregnant may need boosters to certain viruses or bacteria to prevent infections that are teratogenic or harmful to the fetus. Some vaccines fight against toxins produced by bacteria like the tetanus toxoid. Allergy panels are tests of immunocompetence, and the most commonly one done is the tuberculin skin test called the Mannix test. In most allergy panels, one is injected with candida to see if a positive reaction versus the actual test. Failure to react to candida would indicate immunodeficiency. In the Mannix test, the positive response means that the individual has been exposed to TB. It could be infected. It varies based upon the immunological abilities of the individual, as shown here on the CDC guidance. People with HIV or cancer only need a small response, while those who have good immune systems and are health care workers need a larger response to be positive. Antibody titers can be ordered to see how the active acquired immunity's memory is doing. Did the patient have a vaccine or past infection that now will protect them from another infection? This is important, especially for pregnant women or women thinking of becoming pregnant, as viral diseases like rubella can be teratogenic to the fetus. We can test serologically looking for specific antibodies present for infectious diseases, as well as when we cannot find the pathogen by culture. Immune disorders are from over or under reactions. Either the immune system goes overboard in its reaction to an antigen, or it has little to no response. Both can be deadly due to anaphylaxis with the overreaction or sepsis, and death from an opportunistic infection from the underreaction. Here's another table for you to study. This one deals with the 4 types of hypersensitivity reactions. Type 1 is severe allergic reaction like anaphylaxis or asthma reactions, and are IgE mediated and act quickly. Type 2 are transfusion reactions or hemolytic disease of the newborn, and IgG and IgM mediated, and take hours to days to take place. Type 3 are autoimmune diseases we are about to go over, as well as post-streptococcal glomerulonephritis we touched on with the Group A hemolytic strep discussion. This is antigen-antibody complex mediated. Lastly, type 4 is delayed and is from such things as our Mannix TB skin test or graft versus host situations with organ transplants. It is also from poison ivy reactions and is a T cell mediated. Rheumatoid arthritis, or RA, is an autoimmune disease which is a type 3 hypersensitivity reaction that causes joint destruction and inflammation. It is the most common of the autoimmune arthritides. They have morning stiffness with symmetrical joint involvement. They could have rheumatoid nodules around the elbows. You'll find most arthritis cases start in the hands as they are the most used joints. It is the only autoimmune arthritis that causes joint destruction. Diagnosis is made by history and physical examination. RA runs in families and women are affected more often than men. Get x-rays of the hands and involved joints. Test for rheumatoid factor in the serum as well as anti-CCP testing, which is more sensitive for RA than rheumatoid factor. ESR and CRP will both be elevated as there is active inflammation. First-line therapy are NSAIDs and immune system modulators like methotrexate. Systemic lupus erythematosus, or SLE, is an autoimmune disease of mostly women and can affect multiple organ systems. It can have the classic malar or butterfly rash on the face. It frequently has a positive ANA, but that is not diagnostic, as many other autoimmune diseases can have this. It can cause Raynaud's phenomenon or a disease. It runs heavily in families. Diagnosis is made by history and physical and examination, and labs just like the RA. There are 11 criteria for diagnosis. Many have a positive ANA. Those with nephritis may have a positive anti-double-stranded DNA. Treat with NSAIDs, corticosteroids, and anti-malarial drug, hydroxychloroquine and methotrexate. It is interesting how the malarial drug or anti-malarial drug, hydroxychloroquine, works on these patients. It is the most important of the medications listed here. Raynaud's disease or phenomenon is vasoconstriction of arterioles of the hands and fingers, usually due to cold exposure. This causes the red, white, and blue color changes you see here. This is usually associated with autoimmune disease such as lupus, Sjogren's syndrome, or sarcoidosis. Sarcoidosis is another autoimmune disorder. This one is associated with accumulation of T cells and macrophages in organs. This causes granuloma formation. Lungs are a frequently involved organ, as are the skin and the eyes. They can have erythema nodosum. Diagnosis is history and physical exam along with chest x-rays. Biopsy of the granulomas is mandatory. Steroid treatment is the best treatment and can be curative, although some need immunosuppressive agents as well. Sjogren's syndrome, again, is mostly in women. They will have dry eyes, which is keratoconjunctivitis, Zika, and dry mouth or xerostoma. It can be primary or by itself, or secondary, which occurs with other autoimmune disorders like SLE, rheumatoid arthritis, scleroderma. Lab testing for anti-SSA and anti-SSB antibodies can be helpful. Scleroderma is also known as systemic sclerosis. These patients will have a shiny and stretched out skin appearance. They have abnormal accumulations of fibrous tissue with inflammatory reactions and injury to endothelium. Scleroderma can cause CREST syndrome. This stands for calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasias. Calcinosis can cause painful fingers with calcium deposits, and along with Raynaud's phenomenon causing vasoconstriction of arterioles. They will also have thickening and tightening of the fingers on the hands, which will contribute to hand pain. Treatment is similar to other diseases we mentioned. You only need to know these two immunodeficiencies. CMC, or chronic mucocutaneous candidiasis, is a disease of young children with recurrent candida infections. They will frequently have thrush or dermatitis and stay on antifungal medications. Hypogammaglobulinemia is a decrease in IgGs due to defect in B cell development. It must be diagnosed after 2 years of age to allow for normal development of the immune system, delays to be certain. Some patients do not do well and will have multiple opportunistic infections and sepsis. Others do respond to immunoglobulin infusion and frequent antibiotics, but have poor responses to vaccinations. HIV is an RNA retrovirus, meaning it will enter a host cell, CD4, and go backwards from RNA to DNA and become part of the genetics of the cell. It then tricks the cell into making more RNA virus and protein coats and replicates complete HIV copies, destroying the CD4 cells in the process. Some people do not have the receptor that HIV needs to get into the CD4 cell, and they are naturally immune to HIV. HIV has various routes of transmission, usually dealing with exchange of bodily fluids. Those at most risk have unsafe sex. There are men who have unsafe sex with men, and IV drug users are the highest of the risk. The infection will be a flu-like illness, then go away. The HIV may lay dormant for a while, with some cases lasting as long as 10 years before the viral load begins to rise. Antibodies will be detectable by 2 weeks to 6 months after infection. CD4 counts may take some time before they fall, so there is time to start treatment before this happens. HIV positive and AIDS are different. An HIV positive individual has HIV antibodies, but not necessarily has AIDS. In order to have AIDS, an HIV positive patient must either have an AIDS defining illness or their CD4 count must drop below 200. Also, you have HIV positive with a viral load and those who are positive but no viral load detectable. This is important as those with a viral load on their medications cannot transmit the disease very easily. Those with an active viral load, however, are very infectious. Here we have a chart of the initial infection and how it progresses with increased viral load. As the viral load increases, the CD4 count decreases. Remember, AIDS is defined as CD4 count less than 200 or the presence of an AIDS-defining illness regardless of CD4 count. We diagnose HIV by ELISA serological testing first. If positive, then we do a Western blot analysis to confirm. Sometimes there are false positive ELISA tests. This is why the diagnosis is not made until after the Western blot. Viral load and CD4 count are then done if Western blot is positive. Then we can assess how many viral copies the patient has and where the CD4 count is currently at. There currently is not a vaccine for HIV because the mutation rate is so high in this virus. We initiate highly active antiretroviral therapy before the CD4 count drops and in the presence of a positive viral load. If the patient is seropositive for the HIV antibody but no detectable viral load, then we may wait before beginning treatment, depending on patient preference. Prevention of HIV is key, and this includes using condoms if you are male and considering PrEP, or pre-exposure prophylaxis, if you are in a high-risk group. Using PEP or post-exposure prophylaxis is useful if you were exposed to HIV and not much time has passed. You can take this for a short period of time to reduce your chances of contracting HIV. You still must use condoms with PrEP as you can still get other STDs. Complications of HIV are all the diseases and conditions that come with AIDS without treatment of HIV, and without treatment, HIV is fatal in most cases. You are one of the few genetic variations that have HIV resistance, then you might be all right. This ends week 2 lecture. It's time for some applause.